Welcome to the podcast for Healing Neurology, where we talk about everything that can help heal your neurology, which is really everything from food, lifestyle, and medicine to nature, culture, and politics. There's no topic too big or too small. I'm Jillian Ehrlich, family nurse practitioner, certified in Ayurveda and functional medicine. And we have a super smart and super fun guest today. Dr. Alissa Zingman is a physician board certified in occupational and environmental preventative medicine. Prior to medical school, she was a professional dancer and pilates instructor. She also has a connective tissue disorder called Ehlers-Danlos Syndrome, hypermobility type, or hEDS. She's had 5 orthopedic surgeries, several herniated discs in her spine, and has had to leave her orthopedic surgery residency to pursue intensive rehab, or I'll just say rehabilitation for her spine and pelvis. Being a physician did not shield her from the medical neglect and abuse that is unfortunately common amongst hEDS patients, and advocacy remains one of her passions. Her medical practice, Prism Spine and Joint, is a multidisciplinary clinic in Silver Springs, Maryland. Prism stands for Prevention, Rehabilitation, and Integrative Sports Medicine. It's a full-service clinic that combines her experiences as a patient and athlete and as a physician and mom who has spent decades being curious about and caring for her physical body. She has curated a team that offers wraparound musculoskeletal care, alignment, and retraining for patients with physical injuries, pain, and or degeneration. She remains active in biomechanical research and treatment, continues to publish her findings, and plays an active role in the EDS Research Foundation. Find out more at prismspineandjoint.com and the Ehlers-Danlos Syndrome Research Foundation at edsrf.org. Dr. Zingman still does ballet, but only in the pool these days.
That's right.
So welcome. We're happy to have you.
Thank you for having me. It's funny to listen to all of that being read out, especially the abuse and neglect part. I don't know that I have ever personally used those words or would choose them myself to describe my journey. But as you said it, I guess it's not wrong, Yeah. It's just, it's funny. We don't necessarily think of ourselves in that kind of way,
It's amazing to me how many, when I typically see new patients, they spend an unnecessary amount of time reaffirming that they're not crazy. They may have had some anxiety or depression in their past, but this is different. This is not what that is. This is, and I just always think, okay, let's get on with it. But you can see how much the medical system has impressed upon people that it's difficult to diagnose and it's difficult to see what this is.
Yeah, actually, someone on my Twitter feed responded to a tweet that I made recently, noting that there's this whole history in medicine of women having, hysteria and all different other kinds of sort of quote unquote diagnoses to account for the fact that for hundreds of years, women were not adequately researched, were not part of the medical profession, and we're still catching up. And I think that hypermobile Ehlers-Danlos Syndrome and the EDS, full complement of types of EDS, I think all of these syndromes seem to affect women more than they affect their male counterparts on average, not in any individual case, but on average. And so I think that's one of the reasons that, EDS is so far behind some of these other illnesses in terms of time to diagnosis and, treatment available and just how much we understand about the natural history of the condition and all of the effects.
Absolutely. I mean, you and I have even talked before about how other conditions used to struggle with this too. So multiple sclerosis, MS, is the easiest example of before MRI, we thought patients were making it up and that you were just a little stressed out. And that after MRI, once we had the correct tool to see it, then it was like, oh, this is a diagnosis and you either have it or don't. And it's a problem with your nervous system.
Absolutely. And as you know, I use MS as an example all the time because we have been here before as a medical community, and we'll be here again with something else. But, if you look at the past 50 years, how different it is to have MS, how different it is to have rheumatoid arthritis, how different it is to have really a variety of conditions than it was 50 years ago. And the new medications that have been developed that really, we're not curing these conditions. We're not making people no longer have the diagnosis. But we are pretty effectively managing the symptoms for most of the patients, to the point where when I first became interested in being a hand surgeon, I guess, about 20 years ago, which is weird. But some of the older hand surgeons said, 20 years ago, half the surgeries I did were for rheumatoid arthritis degeneration of people's hands. And that was after DMARDs, the disease modifying agents had come out. And now I'm not having to operate on these patients anymore. The younger patients will probably never need a hand surgery. And it's just was such a huge sea change and such a huge shift. And with EDS, I think there is a couple challenges, and probably the biggest one is that the treatment of EDS doesn't fit squarely into any single specialty. Mm-hmm. When you have something like rheumatoid arthritis, well, that's clearly the rheumatoligist's wheelhouse, or MS, that's clearly the neurologist's wheelhouse. And yes, there are other specialties that will be brought in for various things, but who owns Ehlers-Danlos Syndrome? Who owns it? A lot of geneticists that I've heard from my patients aren't necessarily very interested in diagnosing the hypermobile type. They're saying, well, it's a checklist, a PCP could do it, right? It doesn't require my expertise that I have as a geneticist the way that some of these other conditions do. And they're not wrong when they say that. But the primary care physicians aren't feeling equipped necessarily. Some are, who've taken an interest in it, but their training didn't necessarily equip them to diagnose this. Orthopedic surgeons, I can tell you quite certainly, are not trained to diagnose this. I think physiatry, physical medicine and rehabilitation, is what I would love to see become the home of EDS. And it has increased so much in popularity as a specialty. And there's so much that these physicians are actually able to do for these patients with regenerative medicine and nerve stimulators and all kinds of injections. And I hope over time, as we get more research out, that will become kind of the home. But right now, some patients have a neurologist as their quarterback. Some have a physiatrist, some have me, some have a primary care physician who has, a particular interest in this. Some have a physical therapist who's really working very hard to direct their care. And I've talked to some of these physical therapists, and they are so smart and so motivated and so frustrated with not being able to get the patients everything that they need from a physician standpoint.
And let's back up. I think most of our audience is going to know what Ehlers-Danlos or hypermobile type is, but can you give us kind of the elevator speech about what these are, just so we can make sure we're on the same
Sure.
page?
Happy to. So basically, this is a disorder, a heritable disorder of connective tissue. And connective tissue, we most commonly think of in terms of our joint capsules and our discs in our spine and our ligaments and tendons. And certainly all of those things are affected, particularly in the hypermobile type. And there is a lot of spine and joint dysfunction, disability, pain, et cetera. Injury, including injury with no real cause, just spontaneous. I personally ruptured a disc sitting still in a chair.
Whoa.
So that was special. But yeah. That's certainly the most kind of recognized aspect of all of this. But connective tissue is in our gut. It's in our heart. It's in our lungs. It's our blood vessels. It's keeping our organs in place. It's part of how we have the biomechanics of our breathing. It's part of our nervous system. And so all of these areas are affected, and things like gut motility, gut permeability, things like cardiac valves and blood vessel walls, and not just the more common things that we think of, like, is the blood vessel wall having an aneurysm or dissection, but also, can our blood vessels properly regulate contracting so that, for instance, when we stand up, we don't have a significant drop in the amount of blood flow to our brain, which is very common in POTS, right? Postural orthostatic tachycardia syndrome, but also is really happening in terms of orthostatic intolerance in a lot of patients who don't have POTS. And then there's also some immune dysfunction, and the relationship is a topic that is, I think, really fascinating and a little bit, some aspects of it, frankly, above my head in terms of the immunologic side of it. But, MMPs, metalloproteinases, and, what is the interaction there? Mast cells and histamine and, all kinds of really interesting and unfortunate things that happen for these patients that can present in such a wide variety of ways that these patients may walk into almost any specialist's office with symptoms that are confusing. And that's where the problem comes in. And I say this all the time, obviously I've been surrounded by physicians for the past, almost 20 years since I started medical school. Physicians mean well, they want to help their patients, almost to a person. Everyone who I've met went into this with every intention of being as helpful as possible to every patient who walks into their office. And what happens is we end up through our training, and particularly for people who are subspecialized, having a wheelhouse. And when things are not in our wheelhouse, we're really trained to stay in your own wheelhouse because you don't want to make a mistake and you don't want to hurt someone. And while in general, that tends to work reasonably well, when you have something that is affecting almost every part of a person's body, it really requires the physician to step out of that wheelhouse. And sometimes they don't even have the time to do that because of the system in which they are operating. And I don't mean like operating in a surgical way. I just mean, the hospital system that's, you have to see 4 patients an hour or, whatever it may be. And so this is a condition that really requires that extra look, that extra thought, and that extra time. And not every provider even has the option in their job of doing that.
Can you talk a little bit about hEDS patients being like the canary in the coal mine of biomechanics?
Yes.
Is it such a great analogy?
It's funny. It's funny to hear you say my little, whatever you want to call them, catchphrases back to me. Yes, I do say that. So I say, we're kind of like the canary in the coal mine of biomechanics. So I'll take posture as a really simple example. We can all think of our coworkers and our family members and realize that these people don't have perfect posture, right?
I'm sitting up straighter.
You're good, right? And back pain certainly is very prevalent, but it's not debilitating for most people, right? In EDS, if the person doesn't have perfect posture, and I mean like pretty close to kind of perfect, they're going to have a lot more pain than like their next door neighbor with comparably compromised posture. And that is because there will be areas where the strain of kind of having a little extra pressure, let's say into L4-5, for example, well, you're having that extra pressure into tissue that's of poor integrity. And so you're more likely from that additional pressure to get a herniated disc or some sort of other injury in EDS than you are if you don't have EDS. And, I'm using L4-5 as an example, but it could be anywhere in the whole body. And so, repetitive micro trauma from things like, I bent my arm too many times. I just did, an activity that maybe wouldn't hurt the person if they did it 10 times, but if they do it 20 is going to really cause them a week of discomfort that maybe will even require some physical therapy or some manipulation or something to sort of resolve. Whereas if they didn't have the hypermobility, the fact that they were doing that with a little improper mechanics wouldn't have resulted in the bones moving out of place.
It's really interesting. So I'm curious to hear what you think about the most common analogy that I have typically used, which is that when we think about connective tissue, I think good fences make good neighbors. And so what happens in EDS and hEDS is that you don't have good fences. And so suddenly you've got your neighbor sunbathing naked in your yard. Meanwhile, your dog is pooping in their yard. And so there's a greater sense of inflammation and confusion in the cells. So as we were, comparing the hypermobility of our own elbows, every time I think, one of the main things of hEDS is like, don't show your party tricks. But of course, that's the first thing we all do. But I think about like all that connective tissue in there that then is suddenly becoming hypermobile, that it's extending beyond its supposed range of motion, suddenly you have exposure, you have cellular communication, you have cellular crosstalk that is not necessarily supposed to happen. And so your body it can get a little bit more exhausted and a little bit more confused because you don't have those good fences to make good neighbors.
That's great. It's funny. We all have so many kind of like euphemisms or analogies. But one of the things I also say in terms of the fatigue that you just mentioned is that if you want to think of a person who doesn't have a hypermobile body, being upright as stacking wooden blocks, right? Stacking wooden blocks is something an 18-month-old should be able to be very adept at, right? Well, in EDS, depending on your degree of hypermobility, you're stacking sandbags or water balloons. And it's just a harder job. It just requires a lot more tinkering and constant attention and balance. Just being vertical is hard work.
I totally thought you were going to say like ball bearings. I was like, yes.
You can say ball bearing. Yeah, I know that works. Yeah. Something not perfectly square that has that's rounded and mushy, right? So bean bags, I think I said sandbags earlier, but bean bags or water balloons is what I usually say. And then the other analogy I use all the time is, I tell my patients, look, like most people's mom gave birth to a really reliable 4-door sedan, and your mom gave birth to a vintage sports car, and you just can't run a vintage sports car that is 50 years old on the owner's manual of a 4-door sedan that is brand new. You just can't, different owner's manual, different level of care, different level of knowledge about your instrument required, about your car, required, and a different amount of time in the garage, tinkering and making sure things are fine-tuned, different fuel, more expensive fuel, as it were, all of it. So, and the fact that we are, use these type of, this type of language that is so global just shows the point of how much this affects. This is not just what I was taught in med school, which is mitral valve prolapse and dislocating shoulders. It's not just that.
Yeah. Do you think that it's becoming more prevalent? And if so, why?
Yeah, that's a great question. It's really hard to say because I think we are finally diagnosing it a little bit more. But I will say, and this is just my impression, this is not based on any research or data that I can cite, I actually do think it's getting more prevalent. And in talking to my colleagues who specialize in MCAS and neurology and everything, we all kind of think that. And we think it has to do probably with how many more exposures. One of the things that we learned in the environmental medicine, portion of my residency at Hopkins was that we're like orders of magnitude higher in our exposures today. Just in terms of air we breathe, like our food containers, all these kind of things, than like the 1950s, for instance. And we don't really know exactly what these molecules are doing to us. But to me, the chance that they're doing more in the body of someone who, to use your analogy, doesn't have good fences, right, is higher. And it's that canary in a coal mine thing. So if you think about the gut and you think about the fact that the gut in medical school, we're taught, right, the internal portion where your food exists and becomes your stool of the gut is the outside world, right? That's not internal to your body. That is an external tunnel that happens to run through your body, right? So anything that enters your body from that GI tract should have to go through a cell, through a receptor, through a channel, right? It should be meant to go through. But what's connecting those cells and making those tight junctions so that nothing goes between the cells but connective tissue? So if that connective tissue is of worse integrity, perhaps, it's this idea, leaky gut is certainly like a very controversial thing to say, but the idea that someone with a connective tissue disorder would have increased intestinal permeability does not seem to me to be a very avant-garde concept. And I think, if we think about all these substances, maybe given the same exposure in terms of dosage of ingestion, there's a lot like been widely publicized. Oh, we inject a credit card worth of plastic every week, right? Like that's been reported in the Atlantic and all over the place. So, maybe that credit card's worth of plastic, the non-EDS person is only absorbing a fraction of a percent of how much the EDS person is absorbing of those plastics and other things that we're ingesting. Same with skin. I mean, I can tell you from personal experience, my skin is a really lame excuse for a barrier to the outside world.
It can hear you.
Yeah. I mean, it's just like, I don't even know how to describe it, but other people in my family who don't have EDS, when they put lotion on their skin, it's a totally different process than it is for me. I mean, our barriers aren't as good. So maybe all of these chemical exposures are really affecting us. And I'll tell you, Dr. Maitland has said this to me privately. Ann Maitland, who's a really brilliant immunologist in New York at Mount Sinai and a private practice too. Little plug for Ann there. She's, she said, I can give any mouse in a lab mast cell activation syndrome by just exposing them to enough things. Yeah. Right. So maybe our dose leads to a higher exposure than the dose would lead to in someone who doesn't have this connective tissue disorder. So that's just kind of a little, pet theory that is not only mine. I know other people share it, but
do you think, and because this is a heritable condition, what does this look like across generations? Because you can, with genetics, and I don't know, this might not, I know you're not a geneticist, but just in terms of heritability and penetrance, do we find that people with more severe hypermobile EDS then deliver babies that are even more hypermobile? Do you think that this might be progressive?
So all I can tell you with regards to that is my experience with my own patients, which is, several hundred patients who have, either HSD or one of the EDS types, mostly hEDS. I want to say all of them, but I'm going to say almost all of them, just in case I'm not thinking of someone, are sicker than their moms or dads who gave it, who they can identify gave it to them. Now, there are some families where the parents don't have it. I have a family where both parents are carriers that are they're heterozygous for a certain mutation. They had 5 kids, and 2 of the kids ended up having the hEDS phenotype. One is a female, much more affected. One is a male, much less affected. Now, one of their younger children, they think maybe starting to have the phenotype too. But stuff like that happens. But in general, where it's really clear, okay, this hypermobility came from your mom or your dad. My patient is a lot sicker than their parent. Having said that, people whose parents are sicker may have an access problem. So they may not be showing up in my clinic because they may be broke, right? And that is where we absolutely must make sure that we are diagnosing all these patients properly and that they don't need to, patients fly to my clinic from California, Texas, Arizona, all over the South, all over the Northeast, Midwest, England. They fly in from everywhere, and it's a huge expense for them. And nobody should have to do that to get good care. And, I shouldn't have to not accept insurance in order to be able to spend 2 hours with someone and actually give them what they need. So this is a system problem. And that's why it's hard to answer all of these questions.
We're going to talk a little bit about kind of what you do. But before that, let's just do a tiny detour for why is it so hard for this to be diagnosed? How do different doctors agree or disagree on your diagnosis? Tell us a little bit about what's the problem?
So I think, there's a well-established concept of inter-observer reliability or lack thereof, right? And so the more you can kind of standardize something, the better chance you have that 2 different people doing the same process will come to the same conclusion. Current way that we diagnose all types of EDS that are not the hypermobile type is genetic testing. For the hypermobile type, only a fraction of patients with hypermobile type, a minority, will have findings on genetic testing. And a lot of times those findings are variants of unknown clinical significance too, by the way. So that is a diagnosis that is for the majority of patients who receive the diagnosis based on a checklist that was created in 2017 that you can find on the Ehlers-Danlos Society website, which has lots of great information about all kinds of things, including this diagnostic checklist. And within that checklist, there is an inherent certain amount of subjectivity. And I'll give you one example is, you mentioned earlier, like you and me both, our elbows kind of like bend backwards, right? So how much does your elbow bend backwards or hyperextend? That's on there. So if it's more than 10 degrees, you get a point. Well, not everybody's upper arm is just skin and bone, right? So depending on the amount of flesh on the person's upper arm, when they hold their arm out, it might make that angle look kind of different. And what you're supposed to do is kind of feel along for the humerus and try to be along the long axis of the humerus, the midline of the humerus when you're doing your measurement. But I mean, even right there, you can imagine, you have a patient who's in pain, who's trying to hold their arm out and it's hyperextended and you're trying to feel and get it. And you don't want to make them hold the position too long if you don't have to. And where one person, we're talking about, there's a big difference between if it's 9 degrees and 11 degrees in terms of whether or not they might get this diagnosis. There's not a big difference in 2 degrees when you are the person measuring. So would there be some variability there? Absolutely. Right. And then you move on to things like, is their skin soft and velvety? Is it hyperextensible? And you can measure, the hyperextensibility and I do. But even as you move through a lot of that, there is some subjectivity. I will admit, there are many patients who I touch their skin and immediately recognize this is soft, velvety, hypermobile skin, no doubt about it. Then there are some patients who I feel their skin and I say, I'm not 100% sure if this is normal or not. And I call my athletic trainer over and rub her arm real quick, and I'm like, oh no, yeah, there's a huge difference between you two, right? Okay, so, right. But even for someone who does this as much as I do, it's still, there are still times where I second guess myself. And I would assume that that's true for everyone. And then there's, in addition to the fact that the physician or diagnostician's interaction with this document has some inherent subjectivity to it, the document itself is expert opinion, which is not the same as a genetic test. And it was developed by, really very sharp people who live in this space and are great at this. But like, for example, it doesn't include cervical hypermobility. It doesn't include shoulder subluxations. It doesn't include patella subluxations. There's lots of things that one could argue could be on there that aren't on there. And what difference might that make in terms of person A getting that diagnosis when they see this or that provider? And so, and I apologize for anyone who's listening to multiple podcasts by me for repeating myself, but, the more that a physician interacts with that document, the more sophisticated the interaction becomes. And the more that the person might say, okay, look, you're a point shy on this document, but you're a chronic patella dislocator. You have mitral valve prolapse. You've got the skin, you've got the stretch marks, you've got the piezogenic papules. Even though your Beighton score isn't that high, you're have had multiple shoulder dislocations. You've got this, right? And does the person doing the evaluation feel empowered to do that? And how do we get them to feel empowered to do that if they don't? And that is through education and experience. And that's where, sometimes I have people come to me and they say, well, why couldn't, this doctor or that doctor figure this out? And I say, you have to keep in mind, I'm working at a huge advantage here. I have it. I've seen hundreds of patients who have it. This isn't that easy to do. Having said that, it is very doable. And with some education, any physician of any specialty should be able to do this.
Let's talk about, once you have this diagnosis of hypermobile EDS, tell us about your program. And I just, to put a plug in for you, your program is phenomenal. It is so comprehensive, and it's the perfect balance, I would say, of kind of what patients need and to kind of be to feel safe in the moment, and then also to grow into a new trajectory for their own health. So you've got a really good program. And if you have hypermobile EDS and you're like, where can I go to feel better? You should just fly to Silver Springs. So with that slogan.
Hopefully soon that won't be necessary, because we will have more people doing this in more places. I've sort of developed a rubric, a framework for how to approach these patients, because it is, as we've mentioned, really an all-encompassing thing. And so I divide it into 4 stages: organize, stabilize, mobilize, dynamise. And organize, stabilize, I tell people to think of kind of the way a ballerina thinks of doing the bar, or, a football player thinks of doing, drills, and a field goal kicker thinks of practicing kicks. You're never going to be out of organize and stabilize. You're always going to come back to that. Mm-hmm. That's kind of your basics. So let's talk about organize. So I divide organize into 3 basic categories. The first category is the most obvious. It's about the musculoskeletal system. So we need to get the joints into alignment. Mm-hmm. I use actual orthopedic reduction techniques that I've used in the trauma bay. Mm-hmm. We use tons of osteopathic techniques. Breathing is a huge part of your body being organized for a variety of reasons, and requires that your pelvic floor be compliant so that your diaphragm can depress properly. And then we want to restore muscle contractility and proper muscle firing patterns. And we do that both through physical therapy and also through muscle activation techniques, which was pioneered by Greg Rospkoff out in Colorado. So that's kind of part 1 of organize. It's all about the musculoskeletal system. Part 2 broadly is kind of, we want to balance sympathetic tone. Mm-hmm. And so this is where dysautonomia, POTS management comes in, sometimes medical management for that, with medications, as well as lifestyle modifications, management of anxiety. A really alarming percentage of my patients have PTSD. I think treating that is just hugely important. Even for things like joint stability, treating any sleep disorders like sleep apnea. There are osteopathic techniques that actually directly target the nervous system. There are vagal nerve exercises, breath work, and diaphragm and pelvic floor, huge part of this. If every single time you take a breath, you are arching your back, externally rotating your rib cage, shrugging your shoulders, and, giving your body a stress response, that's not going to work out very well. And then this is where I think integrative medicine, some Eastern medicine techniques like acupuncture, acupressure, I'm all for. I use cupping in my clinic, and I kind of, anyone who knows me has heard me say, I don't argue with success. So if acupuncture is making you feel better, please go do acupuncture, Mm-hmm. Part 3 of organize is all about inflammation. Mm-hmm. So that's where we need to evaluate the patient for MCAS. I am really of the opinion that we cannot treat your craniocervical instability if we're not managing your MCAS, or your shoulder instability, or whatever it may be, because your pain, with all that inflammation, your pain signals are going to be amplified, your capsules are going to be weaker, all of that kind of stuff. Rheumatologic management, I believe all of these patients really deserve a good rheumatologic workup. Mm-hmm. And some of them do require rheumatologic medication management because they actually have a rheumatologic condition in addition to the EDS. Things like gut dysbiosis and more of the functional medicine world, in terms of inflammation come in. Dietary changes are huge. And sometimes we just have to do bracing to get some inflammation down. So I'll just put a patient in a C-collar for 2 weeks and just say, look, like your cranial nerve exam is abnormal. You have long tract signs, upper motor neuron signs on your physical exam. Like, we just need to bring the temperature down here and have this pot not be boiling over before we actually start trying to rehabilitate you. Mm-hmm. Let's get you in a brace for a week or 2 and see where we are. So that's organize. Stabilize is kind of actually pretty probably intuitive. It's all about, okay, we got you organized. How do we keep you that way? Right? Mm-hmm. Because I think a really big problem that a lot of these patients have when they go for PT or even osteopathic care is they're kind of getting some stuff put back in alignment, getting some fascial tension resolved. But then as soon as their feet hit the floor and they take that car ride home, they've maybe lost the benefit, or maybe we've even introduced some new motion that they don't know how to stabilize, and they may even injure themselves. Mm-hmm. And so we try, and we can't do it 100% of the time just because of provider availability, but we try really hard in our clinic to follow the motto that like, if you organize it, you stabilize it after. So if I have a patient who has like a little bit of a hip subluxation and a little bit of a pubic symphysis subluxation, and I reduce those and kind of get them back in place, they must do isometrics before they leave, right? That would be an example. So isometrics, the muscle activation techniques and the PT are huge here. I also, and this is sort of along my lines of, I don't argue with success. I do a lot of neurologic retraining techniques. So things like EMDR. So I'll get a patient's neck into like the proper alignment. Ooh. And they can't even talk or breathe without going back out of alignment. So I'll kind of have them stay there and I'll help hold them there and just have them do breathing and eye movements, and I'll have them close their eyes and stroke their earlobes or hands, or have them follow targets and kind of do horizontal saccades and vertical saccades, just like use that as almost like a stabilization exercise for their neck. So we get a little, get a little creative there. But I want patients in the stabilize phase to be able to maintain a neutral spine, CTLS, on their back, on their front, and sitting up. And I want them to be able to do that while they breathe and talk. I don't want them to be like if I hold my breath, I can maintain, my spine in neutral alignment for 10 seconds, right? I want you to be able to, so we have to work on movement initiation patterns, because a lot of patients just, in order to lift one finger up, will clench so many muscles and take themselves out of alignment, right? The stabilized phase sometimes does include some bracing. It often includes regenerative medicine. I really recommend that patients not have any needles stuck in their body until their mast cell is as well controlled as we can get it, without kind of overstaying our welcome of waiting for these injections, because sometimes, you really need the injection. But I'm a huge fan of prolotherapy. For the hips, certainly PRP. Sometimes patients don't have enough of a response to prolotherapy and will, escalate to PRP for other joints or areas as well. But I mean, if there is a joint there or there is a capsule, it is a potential target. So that includes, costotransverse connections. There's little, ligaments there to target. That includes iliolumbar ligaments. It includes all the ligaments around the SI joints and pubic symphysis and ankle and anywhere. Prolotherapy, I'm so personally and professionally grateful for. So big proponent of that. Once the patient is able to kind of, lay down, sit, talk, and breathe without losing their alignment of their spine, we start moving them. So that's where we start working on the mobilize phase. So that's sit to stand mechanics. That's, walking mechanics. It's, again, really focusing on movement initiation, proper biomechanics, start gait mechanics with that patient on their back. Don't start gait mechanics standing up. Start with it on their back with their feet up against the wall, and just let their hip fold and deepen that crease, and have them not shorten one side or the other side disproportionately when they do that, and make sure that they're, using proper biomechanics for very simple micro movements. And then you grow from there. And we use Alexander technique, Feldenkrais, Pilates. I'm trained from the Kane School of Pilates, which I think now has a new name. I also really love Polestar Pilates training is fabulous. And then the dynamise phase, honestly, is very specific to patient goals. And a lot of times patients go back to an in-network PT at this point, as would make sense, because they can really benefit from, what I bring up is something like a heel slide is generally considered to be like the simplest thing you could do with a patient. If you're following this rubric, that's like mobilize stage, right? And it's not even the beginning of the mobilize stage, because it's a big honking movement. You're going from, let's say, 50 degrees of hip flexion to 0, right? So a 50-degree range of motion and asking a patient to control that, some of these patients, it's going to take them 3 months to get there. 6 months to get there, right? And some of the patients are going to come in and they can actually start with that. But the way that I encourage people to kind of test if the patient's ready for that is, can they perfectly maintain that neutral spine in those positions? Can they talk? Can they breathe? Can they interact with you? Can they hand you something and not lose their neutral spine?
Interesting. Yeah.
But yeah, that's kind of my treatment approach that we use at Prism. And it's meant to be more useful than it is meant to be exact.
Yeah.
Yeah.
Well, what's amazing is that we don't think about how often we move. So even when you're laying flat, there's still a ton of that connective tissue movement. Your heart is always moving, your lungs. So, your circulatory system. And so there's a lot of movement, even when we think our musculoskeletal system is still.
Absolutely. And if you're losing and you're doing gripping patterns and losing your neutral spine and moving your shoulder position just to breathe, you're really set up to fail at that point. And we want to set you up for success.
Mm-hmm.
And one thing I didn't bring up is, things like visceral mobilization.
Yeah. Talk about that.
Sag, if you can think of it, it is a problem. And specifically with CCI and AAI, but really with everything.
So craniocervical instability and atlantoaxial instability.
Exactly. Sorry. Yeah. And C-spine in general, you can't treat the C-spine if you don't treat the temporomandibular joint, the shoulder instability. Yeah. If you don't address sagittal balance, coronal balance, it really requires a holistic approach. And the way that our medical system is set up is that you can get physical therapy for one body part at a time. And that just doesn't work well for these patients. We can't treat your shoulder if you have a bunch of slipping rib syndrome going on, rib subluxations all over the place. Your scapula doesn't have a good spot to sit on your back because everything is the anatomy is so distorted. And so it's displaced laterally, which may or may not be called a subluxation, depending on who you talk to, because there's technically not a scapulothoracic joint on the back of the ribs, but there certainly is a home for the scapula on the back of the ribs, that the rib anatomy, when the ribs are in their proper anatomic position, supports, and that when the ribs are externally rotated, sticking out posteriorly and dancing around all which way, the scapula no longer has a good home and it slips laterally. And, I see that every day of the week. So, you can't treat long head biceps tendinitis without addressing the scapula, and you can't treat the scapula without addressing the ribs, and you can't do the ribs without addressing the diaphragm, and you can't do the diaphragm without addressing the pelvic floor, and you can't do the pelvic floor without addressing the SI joints. And I could go on, right?
Isn't that a song, like the knee bone's connected to the thigh bone?
Yeah. Right. Everything I need to know, I learned in kindergarten, they say, right?
Yes.
Yeah. And it's, I have, for any physicians or physical therapists out there listening to it, this is the most fun I've had outside of an operating room, really. Oh, it's fantastic. In terms of mental gymnastics required to solve these Rubik's cubes and figure, I have patients who they walk in the door and I just see from across the room and I know exactly what to do. And I have patients who I've been working with for a year and I suddenly discover something that I'm like, oh my God, I can't believe I didn't discover this sooner, right? There is so much to do. And it's kind of like that polytrauma patient who they've been in a coma in the ICU for 6 weeks and then they wake up and, they go to stand up and they say, I think my ankle might be broken, right? And the team was so busy with their liver laceration and their, splenectomy and, the burn injuries to their lungs and putting a trach in and the fact that their shoulder was shattered and their hip was dislocated, that we never noticed that they had a distal fibula fracture. Right. So, it's like that. And it's really gratifying work when you get those patients who come to you and they are barely getting out of bed or, they're about to lose their job or they have lost their job and, they have really poor quality of life and they're really don't have support. And then a year later, they're doing so much better and they're going back to work or they're dating again, or they're able to be there for their kids more, or, whatever it is. And it's just really, really intellectually satisfying, gratifying work. So I really encourage anyone to take an interest in this population. You will have the most grateful patients and you will really feel that you're making a big impact.
Let's talk a little bit about kind of where the research is now for these patients and kind of where it's going. Like, what are we now finding out and what do we want to know next? Well,
in terms of I can only speak for myself, but I can tell you what I would like to know. So I'm actually going to share with you a little bit of 2 questionnaires that the Ehlers-Danlos Syndrome Research Foundation board and chairs have developed that we're about to start this study. So, I mean, we start with some pretty basic information: gender identity, racial background, ethnic background, education, all that kind of stuff, diagnosis, which type of EDS, who diagnosed you. And then we kind of get into some specific stuff like, have you ever seen anyone of this specialty or that specialty? How many doctors did you see? Did any of them independently identify EDS as a likely diagnosis? From your perspective, how many of these doctors had an adequate understanding of EDS? And it keeps going, and it talks about procedures, that people have had. Did they have it pre or post diagnosis? Did it help? Have you ever received any of the, diagnoses of panic attacks, anxiety attacks, attention deficit disorder, obsessive compulsive disorder, migraine? Did treatment help? I can't tell you how many patients come into my office having seen so many migraine specialists or, a bunch of psychiatrists for ADD, and they actually have cervical instability causing those symptoms. And in thinking about this, I kind of was drawing on my, public health training, where we're really taught to think about, if you want to make an impact in something, you have to recognize who are the stakeholders. So the most important stakeholder clearly is the patient and their family, right? But that's not the stakeholder with the most power. That's arguably the stakeholder with the least power, right? The stakeholders with the most power are the insurance companies, right? And that's obviously flipped on its head from what it should be, but it is what the world that we're living in right now. And so when I'm asking these questions, I want to then be able to take this data and say, hey, guys, you're wasting on average $15,000 on care that didn't help, specialist appointments that didn't help, XYZ, before this patient gets a diagnosis. Why don't you invest in some EDS specialists? Doing diagnosis and actually reimburse people to do longer appointments for these patients. And you'll actually have the patients do better, which is the main thing that we care about, right? And get their care sooner and get better care. But, from your perspective, they're going to have less unnecessary, expensive care. Right. If you do a better job at this, right? So the natural history of EDS is weirdly poorly documented, and then the other part of the survey is about things like, did they have to stop working? Did they have to do disability? Did they, what specific things do they have? What's the most bothersome for them? I can't tell you sitting here today with any certainty, other than I can tell you from my own experience, right? With my patients and myself, but I can't tell you with any degree of certainty, for most patients with EDS at the time of diagnosis, their most problematic symptom is right. That is a question we don't know the answer to. Or the joints. I mean, we know shoulder dislocations and patella dislocations are huge, but are they really more prevalent than ankle sprains?
Yeah, it's a good question.
Right? So through these surveys, and that's just one project that we're working on with EDSRF. We're also doing some stuff with tethered cord. We're doing some stuff with radiology, looking at what imaging do you really need to, diagnose these? What kind of measurements do you need to do? And there's so much to do, and we're tacking away at it the best we can with the available resources. By the way, it's almost the end of the year. It's a great time to donate. We are 501c3.
Excellent. Good.
But just that one survey study, which consists of 2 surveys that we developed, I just feel like has so much potential. And we're kind of at the precipice right now in a sense that anything we do has the potential to have a big impact. And that's both a difficult place to be, right? Because we're not where we'll be in 10 years, right? But it's also an exciting place to be, where people are actually taking an interest in EDS. And, last time I did one of these podcasts, a pretty famous long COVID research team reached out to me to talk to me about, I would say, probably the most widely publicized long COVID treatment team in the country that I'm aware of from my, the news sources I read, reached out to me and said, hey, we'd love to talk to you about your approach. What do you think is the overlap with this and long COVID? And I think there's a tremendous amount of overlap with long COVID and what EDS patients experience.
Absolutely.
And so, all of these connections are starting to happen, and it's, it's the best time yet to have EDS, but it's still a really bad time to have EDS.
Yep.
Because, sorry, my dogs are barking. I was just saying, it's the best time yet to have EDS, but it's still a really tough time to have EDS. It's really hard to find care, and it's really, really hard to get that care covered by insurance.
Yep.
Because a 30 PT session per year limit, or a 20 PT session per year limit, or a one body part at a time PT situation is not what these patients need.
Right.
It's not even close.
All right. So the EDS Research Foundation, tell us about your role there.
I'm the co-founder. I co-founded it with my attorney / friend / patient / co-founder. We're just trying to be as intimately involved as humanly possible.
I see.
Her name is Jen Berman. We joke that she's the lawyer version and I'm the doctor version. We're two sides of the same coin. But so she and I co-founded it. I put together the medical board. We put together the executive board together. We have meetings at least twice a month, and, we're very young. We do have 501c3 status, which is really exciting.
That is great.
And we've only been around for a year. Like, it's a brand new organization, and, we've gotten IRB approval for a number of projects that we're working on.
Great. That's great.
So it's really exciting. It's really hard to find time for, of course.
Yep.
Because obviously, any time I spend on that is just volunteer time, and it's time away from my patients who really need me. And I do have a long wait list, and it's hard to do everything, but hopefully as our funding grows, we will have more, employees, and some of that work can kind of come off my shoulders a little more. And I'm just so grateful to both the executive board and the medical board. For their, they donate their time so generously.
Great.
So it's a fun thing to be part of. And I think that we could have a really big impact over time.
All right. So here with hypermobile EDS, and we've talked about kind of what we call the pentad or the septad patients. We've talked about the other diagnoses that often go with hypermobility, like mast cell activation, MCAS, like CCI and AAI, cervical cranial instability, and atlantoaxial instability. We've talked a little bit about tethered cord. We've talked a little bit about autoimmune disease, or IgG, or kind of all these different types of conditions that seem to come together, and how they don't go into one silo. And we've talked about how hard it can be to get a diagnosis, and then what some of the symptoms are, how they can really be a little bit of anything. If you have a patient who's like, I don't know what's going on, and you don't know either, you might consider EDS. If it's something in their body with their muscles, fatigue,
absolutely,
gut issues.
If it's okay with you, I'm going to just rattle off some things that should be red flags in people's heads.
Yeah, absolutely.
Think of EDS. Functional GI disorders, irritable bowel syndrome, gut dysmotility, rumination disorder. Those for GI, certainly bloating, inexplicable bloating, unexplained weight gain or loss, unexplained rashes, unexplained itching, unexplained feeling of something crawling in your skin. Small fiber neuropathy would be something to think about there too. Headaches, particularly at the base of the skull. Don't forget that TMJ. So temporal headaches, be thinking about TMJ. Any kind of joint instability, ankles rolling, or sort of, myofascial pain syndrome, bladder prolapse, any kind of volvulus, or any, kind of bowel issue that would, be caused by potentially mesenteric hypermobility or something like that. Heart palpitations in particular, anyone with anxiety attacks. I would think about this diagnosis. ADD in the setting, particularly of headaches, and adult onset ADD, I would be thinking about this diagnosis. I think I'll stop there for now.
You've just named all the things that can happen in the human body. And then we've got some ways to be thinking about research and what we want to know about hEDS. You were mentioning epidemiological surveys, cost of care, time to diagnosis, and then the EDS Research Foundation. And then we talked about your 4-step program, which I think is so brilliant because you really do, when you talk about the building blocks, you really do need to like crawl, roll, and move before you can walk, run, bike, ski, climb. And, the time to learning how to walk is much greater than the time to learn, some of these other skills that, based on how often you do them, of course. So really spending that time on containing the nervous system and addressing organization and stabilization that's an amazing and fairly, I think, unique part of a program.
Thank you.
So
I did make it up, so it is probably unique.
You're like,
for better or worse, I had to kind of, innovate a little here. So, we may have a conversation in 10 years where we talk about how narrow-minded and short-sighted I was back in 2021, but, here we are for today.
But that's part of the process, and the work that you're doing is changing people's bodies. And so, Eileen Ruhoy, the neurologist, we talk about it all the time. What we were doing 10 years ago, I think about the patients who came to see me that I was like, and now I think, oh, of course, like it's very clear to me. And, that's how medicine is. That's how life is. That's how individual clinician experience goes. It's just, and sometimes we're on the end of being a patient of a really experienced doc, get later and later into the 2020s who gets more and more information about this. And sometimes we just get the new guy. So that's just how it's going to be. But passing along this information, all the training that you're doing and the mentoring you're doing is phenomenal. And I think franchising your outfit is, I'm all for it. So.
Thank you.
So is there anything else, that we should cover about hypermobile EDS kind of before we close here today?
I'll close with 2 thoughts, one for providers, one for patients. For a provider standpoint, keep in mind that these patients find doctor's appointments largely traumatic. They have a history of not being believed. They are nervous to share their symptoms with you. They are nervous to share how many symptoms that they have because they're nervous that if they say how many things are bothering them, then it will sort of turn into, oh, this must be psychiatric. And these patients are a vulnerable population. And just like pregnant women and other vulnerable populations, they're more likely, I think, in my experience, and this is something that's actually on the questionnaire also, they're more likely to have been victims of abuse. And so when you see someone who seems like they're having a hard time describing their symptoms, take that extra second if you can and sit down and say, you can tell me what's going on. I'm going to believe you that that's what you're experiencing. And I'm going to do my best to try to figure it out. And if we don't figure it out today, that's okay. And you can come see me again, you know? Yeah. And from a patient standpoint, given all the stuff that I just said, I want to help patients understand the framework in which physicians are trained, which is really to identify what the patient's chief complaint or most problematic symptom or problem is, and to try to address that first and address other things secondarily. And while that approach has its imperfections, certainly, and especially maybe for EDS patients, I think that if as a patient, you go in at least with the understanding that that's how your physician has been trained to think about you. Then maybe you can say, the thing that's bothering me the most is I just feel like I can't concentrate. And I know we might not get to everything today, but I'd really also like to talk to you about the fact that my headaches are getting a lot more frequent and, my head feels too heavy to hold up, or sometimes I feel like a shooting pain down my spine and tingling. And I've been having a bunch of weird things happening to me lately. Could I come see you for a couple visits so we can talk about everything? And that way you're kind of approaching it as I'm using my first interaction or my fifth interaction or whatever it is with this physician or whoever it is to build a partnership. Right. Where we're going to be tackling things together. This isn't a one-time interaction. Right. You're not going to get everything you need in one visit as the patient, and you're not going to be able to give the patient everything they need in one visit as the physician. And so don't try to do that. Try to use your interaction to build a rapport and build an understanding and a trust where there can be free flow of communication, and you can have subsequent appointments that can build upon each other.
That's perfect. And it very much is, you got to play the long game with EDS. You got to really set your sights on long-term. So yeah, fascinating. Excellent. Anything else to add?
I think I'm done. But thank you for having me on. Thank you for all the advocacy. I mean, I've thought about having my own podcast and obviously decided not to do it. But I looked into it and found out how much work it was. And so thank you for doing it.
My pleasure. I think it's so important that we get connected, right? So with clinicians who know what you know, to patients who are desperate for help and support. And so it's my pleasure to do it. I always learn a ton. And then, I just get to hang out with people like you. It's been a pleasure. Have a lovely evening. And thanks for having me on. Thank you. And thank you for listening with Dr. Alissa Zingman. We've got lots of ways to continue this conversation through Facebook, Instagram, and Twitter. You can get more about Dr. Zingman from her website, prismspineandjoint.com, and about the Ehlers-Danlos Syndrome Research Foundation at edsrf.org. Please be sure to share this show with your friends, especially your hypermobile friends who are showing you weird things they do with their body, all their party tricks. We welcome your rating and review wherever you get your podcasts, and feel free to send topic requests to podcast@centerforhealingneurology.com. We love that you've joined us today to discuss how to make our whole world medicine. We rise or fall together, and we're committed to doing what we can to make as many of us as healthy as possible. And this takes all of us, including you. Thank you for listening, and see you next time.
Partyfish Media. Partyfish Media acknowledges that it operates and records on indigenous Duwamish and Puget Sound Coast Salish land that is still home to the Duwamish tribe. This land is stolen in violation of the Point Elliott Treaty of 1855. We are committed to uplifting the name of these lands and community members from these nations who reside alongside us. For more information on this land, its people, or ways you can help, visit duwamishtribe.org.